one of the most dreaded complications, one of the most dreaded malignancies that a human can harbor. And carcinoma, malignancies of the lung, are actually very poor with a dismal prognosis. They literally kill the human, they literally kill the patient. Okay, so we'll be dealing with bronchogenic carcinoma. So, what's your idea about bronchogenic carcinoma? Ki jano tumra? Only lung cancer. Everyone knows about it, but what is your basic idea about bronchogenic carcinoma? So, frequently this is one of the most dreaded cancers. This is one of the most dreaded cancers and frequently diagnosed cancers, all thanks to our lifestyle. This is one of the most frequently diagnosed cancer, and a lot is because of a lifestyle. Okay. So in the recent years, we have seen, unfortunately, a rise of bronchogenic carcinoma in women. A rise of bronchogenic carcinoma in women is just because of increased smoking habits. It's because of increased smoking habits, and women are more susceptible to carcinogens as compared to men. Women are more susceptible to carcinogens as compared to men, and that is one of the reasons why in recent years, after taking up smoking, women tend to develop more bronchogenic carcinomas. In fact, when you study about breast, you will see if a woman lives up to, women living up to 90 years, if we do a statistical analysis, 1 in 10 or 1 in 9 women who lives up to 90 years develops a breast carcinoma. But in recent years, what we have seen is, in spite of the fact that so many women develop breast carcinomas, number of women dying from bronchogenic carcinoma is much higher as compared to breast carcinomas. Now, there are many reasons for that, which you will come to know when you study breast. But remember, right now, one of the most frequent causes of death in women is because of bronchogenic carcinoma. It's more than breast cancers, which is much more common in women, but women tend to die because of bronchogenic carcinoma more. Okay, so this is basically a brief introduction, and it's seen in elderly age groups, 5 to 6 decades. That doesn't necessarily mean we don't see it in younger age groups. There are many factors to describe it. Okay, so coming to etiology, probably the most common etiological factors, and everyone knows about it, is smoking. So smoking to hoye gelo, it's very easy, everybody knows about smoking. So smoking jokhon tomra porbe, when you study smoking at your age or at your level rather, you need to know a few things about smoking. Yes, smoke has carcinogens, they have benzoapyrenes and all, which are very harmful for the lungs. But there are a few things which you must know. Ki jinish tomader jante hobe. 3 points when you study about smoking. There are 3 points that you must emphasize on. One is the amount of daily smoking. The amount of daily smoking, how many cigarettes or how many cigars are by no means safe, or how many, whatever you smoke, bidi, cigarette, whatever it is, how many you are smoking. That is important. Number. Got my point? Amount of daily smoking means number of cigarettes that you smoke. Obviously, the more you smoke, the more you expose yourself to the risk of developing cancer. Number 2, tendency to inhale. What does it mean, tendency to inhale? Tendency to inhale kothatar mane ki? How deep you inhale. How deep you inhale. There are people who just, no, that is not going to the lungs, but you're exposing your upper airways. And then, that means it's getting deep into your lungs. So once you inhale deep, you expose the peripheral parts of the lung, not the central part. যদি আস্তে ইনহেল করো, you expose the central part of your lungs. When you inhale deep, you expose your peripheral parts. Okay. Number is duration of smoking habit. Pack years. Pack years. For how many years you are smoking. I think this points, এটা explain করার কোনো প্রয়োজন নেই. These three are hand in gloves. They are interrelated. Amount of daily smoking, tendency to inhale, and pack years. How many, for how long you have been smoking, the duration of smoking habit. Okay. Now, I told you while I was teaching pneumonia, there is something called secondhand smoking. So, these are all first-hand smoking. So, secondhand smoking means, suppose I smoke and you're sitting next to me and you inhale the smoke. So, that is because of cigarettes. Now, suppose there is no one who smokes cigarettes, but you're going out, there's nobody who smokes cigarettes. Cigarette is banned in a city. You'll be fined if you're caught smoking in a public place. Many cities do that. Many places do that. But that doesn't change the fact that those places are devoid of pollution. There can be enough industrial pollutions. So you inhale the pollutants. You inhale the pollutants. Those pollutants can also be, because they also contain carcinogens. For example, benzoapyridine, which is one of the most dreaded carcinogen for the lungs. And when you inhale such poisons, when you inhale such smokes with such kind of carcinogens in it, you expose your lung for development of bronchogenic carcinoma. Okay. So, second-hand smoke is very important. Then come industrial hazards. In industrial hazards, what do you get? One of the most common industrial hazards, have you heard of uranium? In uranium miners, yeah, they do get lung cancers, but more than lung cancers, they get another cancer, which is more common in uranium miners. So, what is it? Huh? Urinary bladder, uranium theke. Yeah, urinary bladder, that is one thing. Then asbestos. Okay, leave uranium. Asbestos. Let's talk of asbestos, which is much more common. When you're talking about lung, let's talk about asbestos. Asbestos is the naam শুনেছো? কি হয়? Huh? Asbestosis তো হয়ে গেল, ঠিক আছে, but that is not malignancy. Malignancy তে কি হতে পারে? Mesothelioma নাম শুনেছো? Tumor of the pleura. So mesothelioma hote pare. Okay. Then these are the industrial hazards. Then there is something called, there's a gas called radon. R-A-D-O-N. Radon. Radon is an indoor air pollutant which can cause lung cancer. Radon is an indoor air pollutant which can cause lung cancer. Oh, radon gas, I've written down, I forgot. Okay. So remember all these things. One is tobacco smoking. Quitting smoking doesn't save you from lung cancer. Quitting smoking doesn't save you from lung cancer. I have smoked for so many years, that doesn't mean that I cannot develop. I may develop, but at a far lesser risk as compared to somebody who still smokes. So remember, tobacco smoke is very important. All these points, these are the points that you must remember. They may not ask you for exams, but you must have some knowledge. It's not that only if you're going to study for the exam point of view. You need to have basic knowledge on bronchogenic carcinoma. So what are the etiological factors that predispose to bronchogenic carcinomas? If an examiner asks you, very easy question, these are the points that you must say. And so when you talk about tobacco smoking, tobacco, at least mention these 3 points: amount of daily smoking, tendency to inhale, and the duration of smoking habits. How long is a person smoking? Number 4 is molecular genetics. Certain oncogenes, proto-oncogenes, tumor suppressor genes are involved. I'll be telling you that when we study about the individual cancers. Okay, so remember, there's something called molecular genetics. And so before we start the types of lung cancers, you must know the precursor lesions. The precursor lesions. What? Before lung cancer, right? প্রথমে কি হলো, ধরো ফর এক্সাম্পল ইউ গেট মেটাপ্লেশিয়া, মেটাপ্লেশিয়া নর্মাল থেকে হলো মেটাপ্লেশিয়া থেকে ডিসপ্লেশিয়া থেকে ম্যালিগন্যান্সি, হয়তো একটা সিকোয়েন্সে আসে, রাইট? সো হোয়াট আর দোজ প্রিকারসর লিজনস? কি সিকোয়েন্সে আসতে পারে? স্কোয়ামাস ডিসপ্লেশিয়া অ্যান্ড কার্সিনোমা ইন সিটু, giving rise to squamous, for example ciliated columnar epithelium আছে, pseudostratified ciliated columnar epithelium যেটাকে respiratory epithelium বলি আমরা, lungs এ আছে, that can, because of smoking or because of certain kind of injury to the epithelium, what can happen? It can undergo, the ciliated columnar epithelium can undergo, this is a columnar epithelium undergoing what? Yes. কি সেটা কি বলে? It undergoes squamous what? Squamous metaplasia. Ciliated থেকে dysplasia তো পরে আসবে. There is a sequence of events, so you do not jump to dysplasia straight away. Ciliated columnar epithelium, everything is normal, then the person starts smoking or there is an insult to the ciliated columnar epithelium. This ciliated columnar epithelium is exposed to a much harsh environment, so because of this exposure, the ciliated columnar epithelium undergoes a transformation. So what is the transformation phase called? Metaplasia. Ciliated columnar, pseudostratified ciliated columnar epithelium undergoing what? Squamous metaplasia. Squamous metaplasia এর মধ্যে থেকে আবার mutation start হতে হতে it can go into dysplasia. Dysplasia থেকে it can go into carcinoma in situ. So what is carcinoma in situ? What is carcinoma in situ? It is malignancy, but it is confined. It is confined by a basement membrane. It has not infiltrated. So that is carcinoma in situ. After carcinoma in situ, if it still progresses further, it goes into invasive malignancy, invasive squamous cell carcinoma. So that is a precursor lesion. Then go to the third one. Atypical adenomatous hyperplasia. Atypical adenomatous hyperplasia predominantly gives rise to what? The adenocarcinomas of the lung. You know what is a squamous? Now, by now, you should know what is a squamous cell carcinoma and what is adenocarcinoma. They must be at your fingertips. Yes or no? All right. So atypical adenomatous hyperplasia predominantly goes towards adenocarcinoma of the lung, gives rise to predominantly adenocarcinoma of the lung. And in between you have dip neck. We call it dip neck, DIPNECH, diffuse idiopathic pulmonary neuroendocrine cell hyperplasia, giving rise to what? Neuroendocrine tumors, the most dreaded of the lot, the worst of the lot, which has the most dismal prognosis with median survival of 6 months, small cell carcinoma or the neuroendocrine cell carcinoma. Okay, so dip neck, diffuse idiopathic neuroendocrine cell hyperplasia giving rise to carcinoids, neuroendocrine tumor, small cell carcinoma of the lung, the most dreaded of the lot. Okay? So just concentrate on this picture. This is a pseudostratified ciliated columnar epithelium. Hanana, why do you call pseudostratified ciliated columnar epithelium? We can clearly make out because looking at the epithelium. Why ciliated? See, you can make out the cilia. What is this phase? It is undergoing a metaplastic change. It is undergoing a metaplastic change, ciliated to columnar, ciliated to squamous. Dysplasia, maybe grade 1 dysplasia. Dysplasia involving only the lower thirds of the epithelium. Dysplasia involving only the lower third of the epithelium. Squamous cells are characteristic features key. When they go up, they mature. Maturity, how is it assessed? They tend to lose their nuclei. They tend to lose their nuclei. Over here, if you consider the basal part, look how much hyperchromatic the nuclei is. Nuclei are, okay. Now compare this part. This has undergone full thickness dysplasia. This is dysplasia, this is dysplasia. So what is the difference between this picture and this picture? Here the dysplasia is confined to the lower third of the epithelium, towards the basal layer, whereas over here the dysplasia has involved, over here and over here, if you consider this too, the dysplasia has involved the entire thickness of the epithelium. So this is basically as good as carcinoma in situ, only confined by the basement membrane. When you compare this last picture, see the malignant epithelial cells, they have breached the basement membrane and they have started to invade the stroma. So that is invasive squamous cell carcinoma, just an example. This is normal bronchial epithelium. This is a glandular epithelium, probably এখানে কিছু metaplastic change আছে, whatever, you don't have to break your head on it. Just see this picture at your level, just see this picture and try to correlate the sequence of events that happens before a normal ciliated epithelium, undergoes transformation to malignancy. তার আগে কি হতে পারে? So the normal epithelium, it undergoes metaplastic change, metaplasia থেকে it goes to dysplasia থেকে it goes into malignancy. Dysplasia থেকে full thickness dysplasia is equivalent to CIS, carcinoma in situ, and carcinoma in situ is as good as a malignancy. It is a malignancy only confined by the basement membrane, and the last stage is if insult keeps on happening, if there is more insult, that insult finally results in what? The malignant cells breaching the basement membrane and invading into the stroma. So that is what is known as invasive squamous cell carcinoma, invasive malignancy. Okay. So coming to see, if you see a WHO book, World Health Organization এর যদি nomenclatures টা দেখো, there's a massive classification. Don't go for it, don't break your head. I'm absolutely sure you're not going to do that. You're wise enough not to do that. So from a practical point of view, we divide malignancy into two parts. One is a small cell carcinoma and the other is a non-small cell carcinoma. Small cell carcinoma and a non-small cell carcinoma. Non-small cell carcinoma is further divided into squamous cell carcinoma, adenocarcinoma, and a large cell carcinoma. At least you should say this parts. At least এইগুলো কিন্তু তোমাদেরকে বলতেই হবে. So divided into, from a practical standpoint, you divide it into small cell and non-small cell. Small cell and non-small cell. Small cell আসছি পরে, that is neuroendocrine, the worst of the lot with a dismal prognosis. Median survival age is in months. I'll be teaching you that. And the other is non-small cell, which is again divided into what? Squamous cell carcinoma, adenocarcinoma, and large cell carcinoma. আসছি আমি সবকটা পয়েন্টসে. So this is basically, just see the location. This picture, this is from this particular book. This is a very good book. Again, I'm telling you because I've taken this from the library and I was revising yesterday. বাড়ি থেকে এত বড় বই আনা সম্ভব না, বাড়িতে আমার সেকেন্ড ভলিউমটা আছে. So I was revising from this book yesterday to teach you. It's a very good book. Just see few points from it. Vinay Kamal. Okay, so this is the same picture which I have put very easily, very good representation. I don't know if your Ramdas Naik has it or not. If Ramdas Naik, if you have it in Ramdas Naik, fair enough, read from it. But in case you want, of course I'm not forcing you, it's a suggestion. You can just go to the library and pick up some points. Don't read the entire book. অনেক কিছু দেওয়া আছে, you cannot read the entire thing. Okay, অনেক extra জিনিস দেওয়া আছে যেগুলো PG level এ লাগে, not at the undergraduate level, but you know what you need at your level and pick up those points, make a note so that it becomes easy for you during the examination. Okay, so see this. What is this? Squamous cell carcinoma and small cell carcinoma, they predominantly arise from the central portion of the lung. Squamous cell carcinoma and small cell carcinoma, they predominantly arise from the central portion of the lung, whereas adenocarcinomas and large cell carcinomas, they predominantly arise from the peripheral portion of the lung. They predominantly arise from the peripheral portion of the lungs. Okay, remember these points. Small cell and squamous cell, exceptions are there, but in general, small cell and squamous cell carcinomas predominantly arise from the central portion, right? And see, squamous cell and small cell. Whereas adenocarcinoma and large cell carcinoma, they predominantly arise from where? The peripheral portion of the lungs. Okay, these adenocarcinomas have a subpleural location. I'll be coming to that. আর এই বইটার একটা ডিসঅ্যাডভান্টেজ হচ্ছে সেম পয়েন্ট বারবার রিপিট করেছে অনেক জায়গায়, If you go through this book, you'll realize same points has been repeated quite a few times and there are a few mistakes. সেটা আমি দেখাচ্ছি পরে তোমাদের কিভাবে. But it's a very good book. We're just printing mistake. The author is extremely good. So comparison, small cell carcinoma, I don't know, I have by mistake, I have put this slide here. You can read, if you take by note, if you take these notes, read the slides later. Okay, by mistake I have put it in the beginning. Okay, আমি এটাতে এখন আর আসছি না, এটা পরে আমি এই করব. So coming, this is very important, location versus tumor. As I have mentioned, small cell carcinoma and squamous cell carcinoma predominantly arise. Small cell carcinoma and squamous cell carcinoma predominantly arise in the central portion of the lung, whereas adenocarcinoma and bronchoalveolar carcinoma is a variant of adenocarcinoma. Okay, so adenocarcinoma, bronchoalveolar, if you want to mention, fine, just a variant of adenocarcinoma, special variant, and large cell carcinoma, they predominantly arise from the peripheral portion of the lungs. Location in the lungs is important. Number 2, cell of origin. এই যে প্রত্যেকটা টিউমার আছে, which cells do they arise from? Which cells do they arise from? So neuroendocrine small cell carcinoma, the tumor small cell carcinoma, they arise from the neuroendocrine argentafin cells or Kulishki cells. Neuroendocrine argentafin cells or Kulishki cells give rise to neuroendocrine carcinoma or small cell carcinoma. Squamous cell carcinoma kotheke arise kore? Squamous cell carcinoma arises from basal cells in major bronchi. Adenocarcinomas from mucous glands in terminal bronchiole. Mucous glands in terminal bronchiole. And bronchoalveolar carcinoma, which is nothing but a special variant of adenocarcinoma, they arise from Clara cells. They arise from the Clara cells in terminal bronchoalveolar region. So cell of origin versus the tumor, this is important. Neuroendocrine cells, neuroendocrine small cell carcinoma, which cells they arise kore? Remember these points, very important. Squamous cell kotheke from basal cells in major bronchi, the mucous glands in terminal bronchiole. Terminal bronchiole, this explains why this arises from the peripheral portions, right? Why adenocarcinomas predominantly arise from the peripheral portion is because most adenocarcinomas arise from mucous glands in the terminal bronchiole. And the last one is bronchoalveolar carcinoma, which is nothing but a variant of adenocarcinoma, and it arises from where? From the Clara cells in terminal, again, terminal bronchoalveolar region. Okay. So these are the various clinical manifestations. Aschi ami pore, these are the various, out of this at least remember hemoptysis, chest pain, ami aschi gulote. I'll come to that, especially when I'll be talking about squamous cell carcinoma. I'll be coming to that, okay. So coming straight to squamous cell carcinoma. Coming straight to squamous cell carcinoma. So squamous cell carcinoma kotheke arise kore, I have mentioned. Basal cells in major bronchi, squamous cell carcinoma. What are the precursor lesions? It should be easy for you now. What are the precursor lesions? What are the precursor lesions? Squamous metaplasia or dysplasia? And carcinoma in situ, okay. Right. Now, these squamous cell carcinomas, era ki kore grow kore? Squamous cell carcinomas, if you consider a bronchi like this, suppose this is a bronchi, so how will a squamous cell carcinoma grow? Suppose this is a bronchi and in squamous cell carcinomas grows like this. So what is this pattern of growth called? Inside a bronchi. Huh? Ki? Endobronchial. It's an endobronchial growth. So this is Squamous cell carcinoma. It has an endobronchial growth, and because it has an endobronchial growth, these tumors are what? If you do a sputum examination, they are exfoliated in the sputum. They are exfoliated means tumor cells, the malignant tumor cells, they fall in the sputum. Exfoliated. Okay, so what is exfoliation? Kono body secretion e jodi kono tumor cells pore jay ba kono cell pore jay, that is called an exfoliation. So this, because there is an endobronchial growth and these tumor cells are exfoliated in the sputum, so if we do a sputum examination, even before the tumor is evident on radiographic examination, on chest radiography, even before that, malignant squamous cells can be demonstrated in the sputum because of exfoliation in the sputum, and that's because of the tumor growing inside the bronchi. It has an endobronchial pattern of growth. Okay, there's an endobronchial growth, and because of this there is an exfoliation in the sputum. So other than this, how will they produce symptoms? How will they produce symptoms? How will this produce symptoms? Because it grows inside the lumen, it will cause luminal obstruction. It will cause luminal obstruction. Okay, and these tumors, sometimes they can rip apart the bronchi and grow into the adjacent lung parenchyma. They can grow into the adjacent lung parenchyma and into the major blood vessels. Bronchi moddhe theke if they grow, they will rip the bronchi apart. Bronchi theke they will come to the interstitial tissue, the lung parenchyma, and can invade the major blood vessels. Hematogenous spread hote pare. Okay, so grossly ki rokom dekhte hote pare? Which vegetable is it equated to? Very common. এখন বাইরে যাওয়া হলে পুরো এখানে চাষ হচ্ছে। Cauliflower. Squamous cell carcinomas are equated to which vegetables? Cauliflower. Cauliflower like growth. So grossly they have gray white. They are gray white. They are firm, solid, firm, and cut surface e ki dekha jabe? There is a gray white to tan appearance. Solid, firm, grossly. They are solid. Cut surface is gray white and the consistency is firm. Areas of necrosis and hemorrhage are common. They can form cavitation. Areas of necrosis and hemorrhage are common. So histologically they can be divided into well, moderate and poor. You should know by now what is well, moderate and poor. So in well differentiated tumors, what you are going to get? Intercellular bridges. Microscopically you are going to get intercellular bridges, the hemidesmosomes, and concentric lamellated keratin surrounded by the tumor cells, So these tumor cells are round to oval with an angular pink cytoplasm and angulated nuclei, squamous cells. They grow in either broad fronds, on nests or tongues. Okay, well differentiated tumors can be identified microscopically by the presence of intercellular bridges or hemidesmosomes and keratin pearls. Concentrated eosinophilic layers of keratin surrounded by what? Squamous cells. So that is known as onion skin appearance. Okay. So this is exactly what I'm talking about. See, can you make out this is an endobronchial pattern of growth? Endobronchial pattern of growth means it's growing inside the bronchus. It is growing inside the bronchus. Endobronchial pattern of growth. Hanana, yes or no? Isn't it? Yes or no? See, this is the bronchus. Yes? So this is endobronchial pattern of growth. It's growing inside the bronchus. So bronchus e gele what would be the clinical features? The most common is cough because of involvement of central airways. Hemoptysis. Hemoptysis because of what? Again, involvement of airways and tumors undergoing fragmentation because of necrosis. Hemoptysis. Dyspnea means breathing difficulties. Keno hote pare? Keno hote pare? Obstruction and what? Because of tumor cells involving the lymphatics, giving rise to massive pleural effusion. Massive pleural effusion. Hoarseness of voice. If the tumor grows into the mediastinum and involves the recurrent laryngeal nerve supplying your vocal cords, you can develop what? Hoarseness of voice. Chest pain. Chest pain keno hote pare? Everything has a reason. Everything has a reason. Why chest pain? Chest pain, buke keno ব্যথা hote pare? If the tumor grows into your ribs and affects the intercostal nerves, right? Intercostal nerve ache? If the tumor grows into your ribs and affects the intercostal nerves, you can develop chest pain. Okay. Superior vena cava syndrome. Superior vena cava syndrome means কখন হতে পারে যদি neck involve করে ফেলে, and this patient will develop superior vena cava syndrome means congestion of the head and neck, cardiac tamponade because of massive bleeding. Paraneoplastic syndrome. Paraneoplastic syndrome, অনেক paraneoplastic syndrome আছে, like Eaton-Lambert syndrome. Then you get because of secretion of ACTH, secretion of PTH, which will cause increase in calcium levels, then gonadotropins causing masculinization or feminization. So there are different paraneoplastic. I'm not concentrating on the paraneoplastic syndromes, which is not the topic today. So squamous cell carcinomas are notorious for giving rise to paraneoplastic syndromes. You know what is a I have taken the class on paraneoplastic syndromes. Okay, and finally, lung manifestations. Bronchial obstruction, collapse, pneumonia, bronchiectasis, lipid pneumonia, etc. So these are the various manifestations that you must remember, especially cough, hemoptysis, dyspnea, chest pain, hoarseness of voice, etc., etc. Okay, so squamous cell carcinoma সম্পর্কে কিন্তু these are the certain points that you have to know. Then, as I was mentioning, you should know the genes involved. You should know the genes involved. So squamous cell carcinoma is oncogenes. Three things you must remember. Oncogenes. In oncogenes, you have FGFR1 and HER2-neu. FGFR1 and HER2-neu. Tumor suppressor genes, P53 predominantly, and RB. What is RB? Retinoblastoma gene. These are the ones which are involved. Okay. Where does the tumors metastasize? Where does the tumor metastasize? Predominantly hematogenous, তো কোথায় কোথায় এটা metastasize করে? প্রথমে হচ্ছে via lymphatics, তারপরে hematogenous. So lymphatics এ কোথায় কোথায় spread করতে পারে? Hilar, media and mediastinal lymph nodes, and sometimes cervical lymph nodes. Pancreas tumor এর নাম শুনেছো? Have you heard of pancreas tumor? আমি একটু just explain করে দেবো what is a pancreas tumor. Okay. Number 2, extrathoracic lymph nodes. Extrathoracic lymph nodes এর মধ্যে এটা explain করলাম আমি। প্রথমে হচ্ছে hilar tracheobronchial, then extrathoracic এর মধ্যে হচ্ছে mediastinal and cervical. So these are the lymphatics. Then comes blood bone. Blood bone এ কোথায় কোথায় যেতে পারে? Liver, pancreas, adrenal glands. Adrenal glands এ যদি যায়, it remains asymptomatic. Kidneys, brain, bones, vertebra, spinal cord. So these are the hematogenous spread. These are the hematogenous spread. Need not remember the immunohistochemical markers of squamous cell carcinoma. There is P40, P63, cytokeratins, CEA, EMA now. Not at your level. They will not ask you. যেটা আছে বলে আমি দিলাম. If you want to remember, fine. If you skip it, the examiner should not ask you. If you can answer these ones, that will suffice. Immunohistochemistry is not for you. If I am the examiner, I'll never ask you. Okay. So, but at least these are the points, risk factors are the ones you know, they are pretty similar. Cigarette smoking is very important, is a major risk factors. Okay. So at least from this part, the ones that you should know are risk factors, which has been explained, clinical features, genes involved, and these. Spread, the metastasis. You have to know. So this is basically the same thing, how squamous cell carcinoma looks like. What is this? What is this? This is the picture which I have shown you previously. What is this? Squamous cell carcinoma, eta ki jinish? Concentric, pink, eosinophilic, keratin pearls. Keratin pearls seen in well differentiated squamous cell carcinoma. Okay. Leave all those. This is see the tumor in these are the normal lung periphery. This is what gray white to tan appearance. So this is the tumor growing in the central portion of the lung. Squamous cell carcinomas are predominantly centrally located. Okay. Egulo ki. This is probably a sputum examination showing squamous cell carcinoma. And eta ki bolo to? What is this? This will not be asked, just for your general knowledge I am telling you. What is this? That is also a squamous cell carcinoma. Seen in fluids or sputum, whatever, body fluid. Sputum is a body fluid, right? A particular cell take ki bole bolo to? Just asking for your general knowledge. Bangachi dekhecho, Bangachi tadpole dekhecho. Have you seen a tadpole? This is called a tadpole cell. This is pathognomonic of squamous cell carcinoma, tadpole cells. And see how brightly eosinophilic these cells are. How brightly eosinophilic these cells are. They are known as, that particular cell is known as tadpole. Banger bacha basically, bangachi. Tadpole cells. So you won't forget, right? There are certain points, if you hear, you will never forget. So that is basically a tadpole cell. Pathognomonic for squamous cell carcinoma, never seen in histopathological sections, always seen in body fluids. Okay. So, acha. So আমি যেটা বলছিলাম apical tumor, অনেক tumor হয় না squamous cell carcinoma, আমি এখানে explain করি, it's not needed for you, so I haven't explained. দাঁড়া এখানে দেখিয়ে দিচ্ছি আমি. This is basically a squamous cell carcinoma which is located in the apex of the lung, right? Ota apex to. This is known as located in the apical portion of the lung, and that is known as a Pancoast tumor. Pancoast tumor. So what do? They invade the cervical sympathetic chain. They involve the cervical sympathetic chain. Ar kothay kothay involve korte pare? Lung, think of your anatomy. Cervical sympathetic chain ke ar kothay? হ্যাঁ কি বলে সেই জিনিসটাকে? So cervical sympathetic chain এ কি হতে পারে? Horner syndrome, ptosis, drooping of eyelids, meiosis, shrunken eyes, anhidrosis, enophthalmos, etc. Okay. আর কি হতে পারে? That is Horner syndrome. Horner syndrome ছাড়া আরেকটা কোথায় হতে পারে? Cervical sympathetic chain হলে হয়ে গেল. Clump case paralysis, Alps paralysis কোথায় হয়? Brachial plexus. So it can also involve your brachial plexus. হ্যাঁ না, অ্যানাটমিতে ছিল কি brachial plexus? হ্যাঁ, in the apical portion of the lungs. Okay, and giving rise to Horner syndrome and brachial plexus injury. Squamous cell carcinoma. This is so. Which is squamous cell carcinoma here? This is a squamous cell carcinoma. I'll be studying adenocarcinoma now. This is a squamous cell carcinoma, and squamous cell carcinoma appearance একটা জিনিস আমি মেনশন করতে ভুলে গেছি. Squamous cell carcinoma necrosis এর জন্য কি হয়? They are extremely fragile. So sometimes because of that granularity, fragile, they become granular, and that sometimes gives an appearance of a cheese. তো তাহলে তুমি কার সঙ্গে কনফিউজ করতে পারো? টিউবারকুলোসিস এর সঙ্গে। হ্যাঁ? Caseous necrosis, very good. তো কোথায় দেখা যায় caseous necrosis? Tuberculosis. Very good. Caseous necrosis তো হয়। Necrosis to hoy tumor er songe. So very good answer. You can confuse it with caseous necrosis. That means it can be confused with tuberculosis. Okay, and see, this is adenocarcinoma, which I'll be starting now. Adenocarcinoma, squamous cell carcinoma prognosis is poor, but as compared to small cell carcinoma, better. As compared to small cell carcinoma, it is better because at a very early stage in sputum examination, you can at least diagnose the case. Okay, metastasis comparatively late hoy. So this is squamous cell carcinoma. So look at the granular cheesy appearance, all because of necrosis and fragility, and this is an adenocarcinoma on the left hand side. So squamous cell carcinomas are in the center, whereas adenocarcinomas are more towards the periphery. Chobita clear? Now adenocarcinoma, how would you identify adenocarcinoma? Adenocarcinoma is increasingly growing in women. So how would you identify adenocarcinoma? Adenocarcinoma jodio women e hoy kintu eta kintu smoking er songe association with smoking is comparatively a little less. Association with smoking is comparatively a little less. So adenocarcinoma, how would you identify adenocarcinoma? Ekdom straight away, coming to the point. Adenocarcinoma, there will be glandular differentiation. Squamous e kono gland thakbe na. Adeno means it arises from the glandular epithelium, right? So there will be what? Mucin production. Very good. Glandular differentiation with mucin production. Glandular differentiation with mucin production. অনেকগুলো ভেরিয়েন্ট হতে পারে। অ্যাসাইনার ভেরিয়েন্ট হতে পারে, papillary variant hote pare. Assigner variant means growing in acini. Papillary means growing in fronts of, growing like papillae. Then bronchoalveolar, ota ami bolechi lipidic pattern of growth, ota ami pore bolbo. And sometimes solid, jodi khub poorly differentiated hoye jay na, it becomes solid. Peripheral location arise from broncho, egulo sob amar bola hoye geche. I have explained all these things previously. Grade, well differentiated, moderate or poor. Well differentiated, you can make out those mucin production and they will be in the form of glands. They will be in the form of glands. Okay. Adenocarcinoma kintu early metastasize kore. It metastasizes early to the tracheobronchial and extrathoracic lymph nodes, and rest are hematogenous. The similar liver, brain, bone, adrenals, lungs, adrenals, kidneys, pancreas, etc. etc. So adenocarcinoma কয়েকটা জিনিস তোমার মাথায় রাখতে হবে কি করে ওরা গ্রো করে। So grossly the tumors are solid. Grossly the tumors are solid with glistening appearance. যদি mucin থাকে না, it will give a glistening appearance. Okay, and there are 4 patterns of growth: acinar, papillary, bronchoalveolar, and solid. There is early, it is not association with smoking is less. Association with smoking is less, and there is early metastasis to tracheobronchial and extrathoracic lymph nodes like mediastinal lymph nodes and all. Okay, then hematogenous spread, similar, quite similar. Okay, immunohistochemistry, if you want to remember, fine, otherwise no need. They are positive for cytokeratin, EMA, epithelial membrane antigen, to a certain extent CEA, carcinomembranic antigen, then TTF, thyroid transcription factor. Molecular genetics, similar, only এখানে উল্টে যাচ্ছে squamous cell এর সঙ্গে। এখানে predominantly কোনটা involve করছে? RB, then P53. RB, P53, and other genes involved include KRAS and all. Okay, so adeno ছবিটা দেইনি নাকি? ওহো, ঠিক আছে, no issues. So bronchoalveolar carcinoma is a specific pattern of, a specific variant of adenocarcinoma which has a comparatively better prognosis. This is because it grows along the alveolar wall. It grows along the alveolar wall. So this is basically a bronchoalveolar carcinoma. Here the malignant cells, they grow along the alveolar septa without invasion, and that is why they have a comparatively better prognosis. So what is this pattern called? This just looks like a butterfly sitting on a fence. Butterfly sitting on a fence, and that particular pattern is known as lipidic pattern of growth. and that particular pattern is known as lipidic pattern of growth. Okay, just remember this. So these are all the growth patterns. See, they're arranged in glands. Hanana, they're arranged in glands. They are all arranged in glands. Just see the glands. That is more than enough for you. You don't have to look into the microscope and diagnose a case of adenocarcinoma. So I'll be putting you the easiest one. So the easiest one for you is, this is an acinar configuration. These tumor cells are growing in glandular configuration, Hanana. And in bhetore you can see mucin. In between you can see mucin, right? Okay? অনেকক্ষণ হয়ে গেছে আজকের ক্লাসটা, and the last one won't take too much time. It's a big topic, I know. It's a big topic, so I'm finishing it in one class. At least I should take 2 classes for it. So small cell carcinoma. Small cell carcinoma is also like squamous cell carcinoma, is associated with paraneoplastic syndrome. Paraneoplastic syndrome. I bolechi which paraneoplastic syndromes. Straight away coming to the growth pattern. Here, this is endobronchial growth. Small cell carcinoma is not endobronchial, but it is peribronchial growth. Means what? It grows around the bronchus. It grows circumferentially around the bronchus. So it doesn't obstruct the lumen, but it causes, with increasing size, it causes pressure. It causes pressure in the lumen, narrowing the bronchial lumen, right? So it narrows down. It's a peribronchial pattern of growth, and it narrows down the bronchial lumen. Mind it. It narrows down the bronchial lumen. Most aggressive, associated with cigarette smoking. Ekhane not associated cigarette smoking likheche, it's wrong. It's a bhul printing. There's a wrong printing. It is very much associated with cigarette smoking, and it has a worse prognosis. And there is widespread metastasis. By the time a small cell carcinoma is diagnosed, it has already metastasized far and wide, and that is one of the reasons why patients with small cell carcinoma has such a poor prognosis. And it is associated with various paraneoplastic syndromes, just like squamous cell carcinoma. Okay, and these are the paraneoplastic syndrome. Eaton-Lambert syndrome. Eaton-Lambert syndrome is because of formation of IgG antibodies against the voltage-gated calcium channel, so acetylcholine is not released. Patients have what? Pelvic girdle, muscular weakness, then proximal limb weakness, etc., etc. Okay, this is beside the point now. Paraneoplastic syndrome er upor ami ekhon jor debo na. Then what are the other? Peripheral neuropathy, cerebellar degeneration, etc. So it is associated with paraneoplastic syndrome. Paraneoplastic syndrome. Which are the genes which are involved here? 3 things you must remember. One is the oncogene, CMYC oncogene. Then tumor suppressor genes. In tumor suppressor genes, predominantly retinoblastoma gene, 80 to 90%, or 50 to 60% is P53. An anti-apoptotic gene, for example, BCL2, is highly expressed. There is overexpression of anti-apoptotic gene, BCL2. Okay, and coming to immunohistochemistry, just remember the names if you want to. NSC, neuron-specific enolase, synaptophysin, chromogranin, and LEU7. So these are the various immunohistochemical markers which are positive for this small cell carcinoma. So as I have mentioned, this is associated with cigarette smoking and with a worse prognosis. Morphology ta ekটু jante hobe. The morphology is striking. It doesn't look like adeno or squamous cell. These tumor cells are extremely small with scanty cytoplasm. These tumor cells are extremely small, round or oval shaped with scanty cytoplasm. Okay, the nucleus, there is nuclear molding with a salt and pepper appearance of the chromatin. With a salt and pepper appearance of the chromatin. The chromatin is granular, grains er motan. Because of that, it gives the appearance of a salt and pepper pattern, which is characteristic of small cell carcinoma. The cytoplasm is scanty, I have mentioned, with a high mitotic rate, 6 to 7 mitosis per high power field. 6 to 7 mitosis per high power field. So this is the one which I have just explained, and their prognosis is very bad. So this is exactly what I mean to say. Round to oval, or spindle shaped cells with scanty cytoplasm, and chromatin টা যদি এখানে বুঝতে পারছো না, যদি মাইক্রোস্কোপে দেখা হয় না, there is a granular appearance of the chromatin, সেটাকে বলে salt and paper appearance, ঠিক আছে? Then comes large cell carcinoma. I'm not explaining large cell carcinoma, neither it shows a, obviously it will never show a small cell differentiation as the name suggests, large, so it neither shows a squamous differentiation nor a glandular differentiation. Okay, that is why it's called a large cell carcinoma. Very bad prognosis. It has a excuse me, it has a very bad prognosis. Just remember the name. This part is very important. Diagnostic modalities. যে কোনো malignancy কিন্তু তোমার diagnostic মানে lab investigations টা চাইবে, how do you diagnose, 7-8 marks থাকে কিন্তু, so you have to know. I have made it as easy as I can for you so that it becomes easy for you to represent in the answer script if you are asked one. Chest x-rays, okay. Mediastinoscopy আমরা কখন করব? Mediastinoscopy means when we suspect mediastinal involvement. CT scan enables the surgeon to know if the tumor is resectable or not. So any lymph node, any draining lymph node more than 2 cm in size is likely to have been involved by squamous cell, by bronchogenic carcinoma, or if it is less than 2 cm in size or less than 1 cm, it is unlikely to be involved by metastatic deposits. Got it? So CT scan enables a surgeon to know whether the malignancy is resectable, the tumor is resectable or not. So ওখানে draining lymph node size দেখা হয়. If the draining lymph node size, if the lymph node size is more than 2 cm, the draining lymph node is probably involved by metastatic deposits. Lesser than that, unlikely. Okay. Then you get MRI, magnetic resonance imaging. MRI কি করবে? To know metastasis in various sites, say brain, spinal cord, bone, say tumor deposits আছে কিনা, that will be picked up by MRI. Okay, কি লিখেছি? To evaluate metastasis কোথায় হচ্ছে? Various organs এ metastasis হলে। PET, positron emission tomography, positron emission tomography, and if PET is combined with FDG, radio labeled FDG, fluorodeoxyglucose, it helps to identify the malignant cells. So if this FDG, fluorodeoxyglucose, has affinity for cells of the body, but when it comes to malignant cells, it has more affinity. So the FDGs are more attracted towards malignant cells. So in malignant cells, they enter the Krebs cycle and cannot compete it. So metastasis in various sites can be identified by PET, positron emission tomography, and if you radio label it with FDG, fluorodeoxyglucose, a compound which has affinity for malignant cells. So in malignant cells, they enter the Krebs cycle but cannot complete it. So they are identified. Okay. Then comes fiber optic bronchoscopy. Bronchoscope is introduced into the lungs. Okay. And the lesion is identified. And the fiber optic bronchoscopy also helps to take representative samples for further ancillary tests. Okay. Just remember the names, fiber optic bronchoscopy. Sputum examination I have explained, predominantly in squamous cell carcinoma. Bronchoalveolar lavage, saline is injected into the lungs and the saline is taken out and looked for malignant cells. Bronchoalveolar lavage. Finally comes biopsy, jeta histopathology te amra dekhi. It can be bronchial, transbronchial, ultrasound or CT guided biopsy, percutaneous needle biopsy, open biopsy, whatever biopsy, ওখানে formalin fixed specimens দিতে হয়. So points to be remembered while reporting, যে জিনিসগুলো তোমাদের just জেনে নাও, এটা তোমার না পড়লেও চলবে. Diagnostic features include tumor margins. As a pathologist, we need to know tumor margin. Tumor margin evaluate করার importance কি? We need to know whether the tumor has spread. মার্জিনের বাইরে সার্জন তো টিউমারটা রিজেক্ট করলো, কিন্তু যদি মার্জিনের বাইরে আবার মার্জিনে যদি আমরা বায়োপসিতে দেখি যে টিউমার ইজ দেয়ার, we need to inform the surgeon that the margin is involved, which effectively means it has spread beyond the margin. So tumor margins is very important. Then histopathological type, squamous, na small, na large, na adeno, na bronchoalveolar, whatever, because প্রত্যেকটা একটা আলাদা প্রগনোসিস আছে। গ্রেড, lymphatic and blood vessels involvement, কেন? whether it has metastasis হয়েছে কিনা। lymphatic বা blood vessel involved যদি হয় তাহলে we can suspect a metastasis to distant organs, right? Immunohistochemistry, don't have to worry, এটা just বাড়িয়েছিলাম আমি। So I think, so this is where this topic ends, and the harsh, what I have said, the harsh reality of medicine which many of you will be doing is this,